Hello and good evening, friends. Welcome to yet another episode of ACNS webinars. Today is the first webinar of the month of April, and indeed it is a very special day as we are greatly honored by the presence of the great faculties who have inspired generations of neurosurgeons around the world. The first speaker for today is Professor Robert Spetzler from Arizona, USA. Professor Spetzler served as the president and CEO of the Barron Neurological Institute from 1986 to 2017. He is also the emeritus chair of the Phoenix campus of the University of Arizona College of Medicine. Professor Spetzler is a world-renowned neurosurgeon who specializes in cerebrovascular disease and skull-based tumors. He has been involved in pioneering the techniques of hypothermia and cardiac arrest for the treatment of difficult brain lesions. He has been honored by several societies across the globe, and in 1994, Professor Spetzler was chosen as the honored guest of Congress of Neurological Surgeons. At the age of 49, he was the youngest recipient of this prestigious honor. He is a noted researcher and has authored tons of literature in various peer-reviewed journals and textbooks. We are extremely honored and thankful to Professor Spetzler for accepting our invitation to be a speaker at our webinars. Today, Professor Spetzler is going to share his experience in the management of deep-seated cavernomas. The second speaker for today is our honored guest from China, Professor Hui Zhang. Professor Hui Zhang is the professor and chief surgeon, Department of Neurosurgery in the first affiliated hospital of Harbin Medical University, Harbin, China. He was a former visiting scholar at the University of Iowa and Cleveland. He is a standing commissioner for neurosurgery and neurointerventional group. Neurointervention is his specialty, and today is going to talk about endovascular management of symptomatic intracranial atherosclerotic stenosis. The first chair for today is one of the most famous faces of Japanese neurosurgery, Professor Shigeaki Kobayashi. Professor Kobayashi is the professor emeritus of the Shinshu University. He currently serves as the honorary director of the Stroke and Brain Center at Aizawa Hospital, Matsumoto, Japan. Professor Kobayashi is the president of the prestigious Roten Society. He was the past president of the Japanese Neurosurgical Society and the Japanese Society of Neurological Surgeons. He was the treasurer, second vice president, and honorary president of the WFNS. His illustrious career is studded with awards and recognitions that he has received across the globe. His field of professional interest includes cerebrovascular surgery, brain tumor surgery, neurosurgical instruments, and robotics. We are extremely grateful to Professor Kobayashi for accepting our invitation to chair today's first session of webinar. The second chair for today is our honored guest from China, Professor Xu Bin. Professor Xu Bin, who is a hybrid surgeon, is affiliated with the Huashan Hospital, Fudan University, Shanghai, China. He is one of the most prominent faces of modern cerebrovascular surgery around the world, with the largest number of bypass for myocardial disease. He has been our main mentor and support from China, and we are indebted to him for supporting the educational activities of ACNS. We are extremely thankful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and President Professor Yoko Kato, I would like to welcome both the speakers and chairs for today to this online platform of ACNS webinars. Dr. Liu Boon Seng from Malaysia is my co-host for today. And with that introduction, I would like to hand over the platform to Professor Kobayashi.
Thank you, Dr. Braja. Good evening, good morning, everybody. This is Hugh Robert. I'm very honored to be chair for Dr. Spetzler, talking today about the brainstem cavernous malformations. And I would like to start right now because we like to have a lot of time for discussion and what he has to say. Dr. Spetzler.
Good morning. It is indeed a pleasure to discuss with you one of my favorite topics. So it is indeed a pleasure to be talking about one of my favorite topics to all my friends in Asia. I have visited so many of the countries in that part of the world, and so I have many friends and colleagues like Shigeaki. The cavernous malformations are the lesions that have taught us more about how to get to all places in the brain than any other lesion. And they have made us find routes that beforehand we never really even considered were possible. So I will attempt to give you my feel for deep, difficult brainstem and spinal cord and thalamic cavernous malformations. I've had the fortune of treating well over 1,000 cavernous malformation and well over 500 brainstem cavernous malformations. So the goals of this presentation is what we know, very important, the contraindications for surgery, the indications for surgery, the decision rationale, safe entry zones, and then finish with conclusions. So one of the problems with cavernous malformations is that we have treatments like radiation or medication, and the problem is determining what is success. So if you have a cavernous malformation like this that is hemorrhaged, and you radiate and you have this result, you would call that a very good success. When in fact, the only thing that happened here to here is time, and the hematoma has reabsorbed, and therefore this would be a cavernous malformation that is still very much alive. And in fact, 2 years later after this MRI scan, it rebled. When not to operate? Very simple. When the risk exceeds the benefit, when you're likely to hurt somebody. And if you imagine this is your daughter or your mother, and you look at this and she has very few symptoms, there is no good neurosurgeon would say, we ought to take this out, because going through the floor of the fourth ventricle will certainly cause a neurologic deficit. So how often did we at the BNI actually operate on patients that had brainstem cavernous malformations that were referred to us for surgery? And so over a 2-year period, Dr. Hahn recorded all the patients that came and the recommendations we made. And of those 87 patients, we recommended no surgery in almost half. Remember, these were patients sent specifically for surgery. For the indications for surgery, I think a lesion that comes to an accessible peel surface is fairly straightforward. If they have repeated hemorrhages, if they have a progressive neurologic deficit, if they have significant mass effect, and if they are deep, but they have a safe entry zone. And that is really the crux of the matter. We've published many, many papers on cavernous malformations, and there is no doubt that cavernous malformations, in my mind, are venous lesions. They are a budding process of abnormal veins. The prevalence, there's symptomatic bleed in a prospective study, but really the population we're looking at are those patients that have had a clinical presentation, and then when you look retrospectively of those that have presented, the hemorrhage rate is between 3 to 5%. More importantly, the rehemorrhage rate, and this is actually from a study in Japan. The rehemorrhage rate, if a patient has presented with a hemorrhage from a brainstem cavernous malformation, the risk of repeat hemorrhage is very high. And that's because the brainstem doesn't tolerate very small hemorrhages without causing a deficit. Without very solid evidence, when I saw a patient with a brainstem cavernous malformation, I mentioned that I thought the risk of a rehemorrhage was in the neighborhood of 7%. Approaches, I've said it 1,000 times, exposure is everything. If you can see the lesion, you can take it out. We have to preserve the large veins that drain the surrounding brain that may very well be associated with a cavernous malformation to avoid a venous infarct. Image guidance makes many of these lesions approachable. Without image guidance, many of these would be inoperable. Obviously, recording of sensory and motor evoked potentials for these deep lesions is essential. Sharp dissection. I like to have the patient in burst suppression, which increases the tolerance for temporary ischemia, and it also decreases blood volume, therefore making the exposure easier. Anatomy, anatomy, anatomy. And then my personal preference is to avoid rigid retraction. We don't have time to discuss all the anatomy, but there are so many great presentations on anatomy. I cannot overemphasize to our residents and our young attendings the importance of learning the various nuances of anatomy. Here's a good example. This is something we published back in 2015, where we looked at our cavernous malformations in the thalamus, and we divided the thalamus into 6 regions depicted here. And as it turns out, each one really has a different approach to provide the safest route. I already mentioned intraoperative image guidance, absolutely essential, and naturally, it is all microsurgery. So when we look at all the various angles that we have, the nuances of whether you go to the right or to the left of the third nerve, all of these are critically important. Equally important is positioning of the patient. For the patient to have good venous drainage, but also to be in a position so that the surgeon can be comfortable. I personally like to have the sitting position with armrests. And then when we get into very small, deep crevices in the brain, because the visual axis and the light axis come in at different degrees depending on the focal length, it'll go between 3 to 6 degrees. When you are very deep, you may not have any light. So adding on instruments that have light on them, these are available from Cogent. You could really see, as opposed to without it, you would have difficulty seeing. Just an example of utilizing a robotic and visualization function. So we have this little posterior occipital cavernous malformation that is hemorrhaged a few times. Here's the pre, here's the post, here's the pre, here's the post. So we put in an entry point and a target point, and the microscope's robotic function will automatically align. And here's an interhemispheric approach. We go right between the hemispheres. We use gravity for retraction, and we just follow the guidance right to the lesion. We're using a suction with a little light on it. As I mentioned, I love this addition of the actual ability to see better. And then we remove the small cavernous malformation, basically not touching the brain. We just go through this little peel opening on the contralateral side. So we've come from across the side, used the robotic function, and here we're pulling it out. Hemisphere, the head is horizontal. Decision-making is key to what we do. So here's a 23-year-old young, intelligent medical student who presented with a sudden onset of severe headaches, and she has this cavernous malformation. Her functional memory is excellent. She's an A student, a superb medical student, and naturally we have to worry about the fornix. So the first question we have to do is, are we going to observe this lesion or offer surgery? Considering the size of the lesion, her presentation, she chose surgery. So if surgery, what approach? Are we going to go interhemispheric? Are we going to go through the lamina terminalis? If interhemispheric, what position? Are we going to do the classic with the head straight up, or are we going to put the head horizontal? Well, I'm a great advocate of the horizontal position. because your eyes are horizontal and your hands are horizontal. So why would you be operating like this with poor visibility when you can be operating comfortably like this? So that's exactly what we did. And with image guidance, we go right down to the lesion. And this is a very straightforward one because we can go ipsilateral right to the cavernous malformation and remove it. One of the lessons that I want to emphasize with this here is actually at the end of the procedure, we need to look around the cavity of the cavernous malformation and make sure we have it all, because recurrences are based on the fact that we missed part of the lesion. So it behooves us to move every little speck, the little white collections of collapsed cavernous malformation. And so spend a lot of time, and you'll find an extra little piece of cavernous malformation that you might have missed. And then by polaring anything that really still looks abnormal, you could see the small little veins that go with it. And again, that was lighted. And here's the horizontal. That's just a small bone flap right across the cavernous sinus, one little incision, and here's the post-op. And she had a normal examination and went back to medical school. Let's take another case of where we have decision. This is a cavernous malformation in the ventricle that has bled 3 times. The question is, what approach do we want to use? Do we want to use transcortical? Perfectly reasonable. Do we want to go interhemispheric, transcallosal, ipsilateral? It's going to be tough to come around here without a lot of retraction. Or do we want to go contralateral, interhemispheric, through the cingulate gyrus to get to the cavernous malformation? This one and this one, I think, are very reasonable. This one is tough because of the lateral location. So this is what we chose. Head is horizontal. Opening is 2/3 in front of the coronal suture, 1/3 behind. The classic approach, still use it. And here it is. There's the cavernous malformation. Image guidance is naturally essential. We come in on one side, no retractors. We identify the pathway with image guidance, cut the falx, and then we're going, because of where we need to open to get to the lesion, we use just a very small opening through the cingulate gyrus to get to the contralateral ventricle. We go right across, and there is our cavernous malformation. We then resect it by polaring all the little veins that are part of the cavernous malformation. And always this pulling against resistance with our other instruments. And then pulling it out. And you can see the direct pathway that this makes possible. Here is the way we went, and basically no effect on the brain. So we're going to go through a series of cases from the bottom up. Spinal cord, we have learned a lot. The beauty of the spinal cord is that it is a small anatomical structures, and we have what I consider three basic approaches to the spinal cord that we can access. The midline myelotomy, very robust. The dorsal nerve root entry zone, and lateral between the nerve roots. And those three approaches are really the route to get to all the cavernous malformations that we encounter. Some of them can be absolutely huge. This little boy from San Francisco actually had a devastating cavernous malformation. I won't show you the anatomy of the video of this here, but it's hard to believe that there's any spinal cord that is really left, and yet he still had some function, same as he had pre-op. This is a more classic one, midline. You can see the veins as part of the cavernous malformation. This was the cavernous malformation in the father. The son had one in exactly the same place that had ruptured. He was admitted to another hospital. He still had some feeling in his legs, so we operated on him, but it was an extra-lesional hemorrhage, and he was relegated to a wheelchair. His father insisted that his cavernous malformation then be out, and his attitude on life was an inspiration to all that he met. More difficult are the cavernous malformations like this here that are off the midline and deep. For this here, we chose the dorsal nerve root entry zone. You see the dorsal nerve roots that are right adjacent to the cavernous malformation. This patient also had pain associated with this cavernous malformation, so it's a perfect approach. And then we just gently go around the lesion. Very important in the spinal cord is to make this incision long enough so you don't hurt the edges as you're removing the lesion. And so this really came out very nicely. More difficult yet is this one that's anterior, off to the side. This was a gentleman from Hong Kong, had 3 repeated hemorrhages. He was a very aggressive businessman, AAA personality. So here we have to go even further lateral. So here's the dentate ligament I'm holding on to. Dorsal nerve root, so we're below the dorsal nerve root, lateral, coming in, going directly to the cavernous malformation. And you can see from the consistency of the cavernous malformation, the different ages of the hemorrhages. And again, you see this beautiful visualization from the approach. Here's a very old hemorrhage. And we just keep going until it's really all out. Here's the post-op. You can see the approach that we took, and he had no change in his examination and was normal. Far lateral approach. What we want to do is we want to get sufficient exposure to be able to get to the anterior portion of the medulla. And so in this particular case, the opening that we create depends very much on where we want to go. How much of the condyle do we have to remove? How anterior do we really have to get? And all of this is part of the decision-making process in getting the approach to the specific lesion you seek to address. So this is an editor from London, and she happens to be the medical editor. She had 3 hemorrhages from this cavernous malformation. You see how anterior it is. And through a relatively small far lateral approach, we are now in front of the medulla. You can see the vein that goes into the cavernous malformation. And you can see again the different ages of the hemorrhages with the fluorescent orange, the contracted lesions. Here's the 11th cranial nerve. And we just continue to take it out. Everything depends on the exposure. So we can see where we are through a far lateral approach. The beauty of the far lateral approach. She actually wrote a book about her experience, which is on Amazon.com UK. A very good writer. Suboccipital approach naturally is a workhorse for all of us. And the midline approach but more importantly, the T-lobular approach, which gives us lateral access and is very safe. So for the suboccipital approach, I like to have the patient prone or in a lateral position if required, so that I can sit and be comfortable. As I mentioned, the ventricle, the brainstem, is so full of incredibly important structures. You have to be very careful. A midline approach in a patient that has a normal floor is very, very risky. Much better is to go lateral. So in this case, this is a patient that already has significant deficit, so it's not a problem to go through the floor of the ventricle. You can see the bulge. The head is here, the feet are up here. I'm sitting at the head, opening, and just once we've removed the hematoma, then it becomes really relatively straightforward to remove the lesion. What we want to avoid is causing any additional harm. And now you can see the floor of the fourth ventricle. And she made an excellent recovery, but was left with a deficit that she already had before we operated on her. More interesting for an approach perspective is really the lateral lesion, the one that's off to the side. And this is where we can use the T-lobular approach, which is a robust approach and gives us great access to the laterally placed cavernous malformations. And again, we don't have time for go through the anatomy, but what you're doing is you're coming out the foramen of Luschke, and this is just like it is at surgery. And so open, again, head is up here, feet are up here. We're coming out lateral, just opening all the arachnoid planes. The choroid plexus that's sitting right here. I like putting a piece of gel foam into the fourth ventricle so that CSF tinged with blood can't get there. And then we want to go out the foramen of Luschke. And by going out through the foramen of Luschke, we expose the middle cerebellar peduncle. And when we expose the middle cerebellar peduncle, which is very robust to being able to tolerate an incision, we can then, with image guidance, go right to the lesion. And here we are opening. We'll go right down to the cavernous malformation. And once we've identified it and see it, we can then remove it safely. And here it is. You can see where we were, and the cavernous malformation is gone. Retrosigmoid, another workhorse. I used to do so many procedures through the temporal bone, when so much can be done just through the retrosigmoid approach. Here's a patient with familial cavernous malformation. This one is now symptomatic. However, hearing is still preserved. They'd operated previously through a temporal approach. And here we are, nothing more than the retrosigmoid approach. The goal of surgery is to go through the middle of the cavernous malformation, through the middle, not here, because then you have great trouble getting to here. You want to be equidistant by the forcing. And then the beauty of image guidance is that we know when we're at the end of the lesion. So here we are, no retractors. Patient is in the lateral position, head turned, and here we're walking up the middle cerebellar peduncle. Fifth nerve is out here, and we make an opening. And this is a huge cavernous malformation, so it takes a lot of removal to get all of it out. But we keep going, and we keep going, and we keep removing this cavernous malformation. Until it's really all out. Clean it up, make it dry. And this is what it looks like. Empty cavity. Left hearing was still preserved. I put this one in because the cerebellum really is uniquely available to go through the middle cerebellar peduncle in what we call the petrosal approach. So we open the petrosal fissure. So just like the Sylvian fissure, we dissect all the arachnoid adhesions. Petrosal vein, I always leave it intact. It's a good reminder never to over retract. And then we just keep following. And then we go into the petrosal fissure until we have the exact angle that we want for the approach to that cavernous malformation. So you see, we just keep opening. This is no different than the Sylvian fissure, except the cerebellum is more fragile. It doesn't tolerate any retraction. So we just keep going here. We see the fifth cranial nerve down below, but now we just keep opening this petrosal fissure. And then when we see the white structure, that's the middle cerebellar peduncle. And that's what we want to do. That's where we want to go. Now you see how wide it is? Now we have, with image guidance, we have our direct trajectory. We go through the middle cerebellar peduncle until we get to the lesion. And there's the cavernous malformation, and that's easily removed. But opening the petrosal fissure is key. And here is the empty cavity. Supracerebellar, infratentorial, just fabulous. I mean, the fact that the tentorium goes all around, we can go very lateral, the most being naturally the far lateral. But this is such a beautiful avenue to going through the medial lemniscus to get to the cavernous malformation. Very well tolerated. Here the patient is either prone or lateral, depending on the ability of the neck musculature. No retractor in place, no retractor. And we just go between the cerebellum and the tentorium, and we remove the lesion. Everything is exposure. The only retraction are my instruments. And here's the post. And that's what it looks like. You can see how we came in just on this angle to get it out. How far can we go with this approach? This is a patient that had previously been operated. He now is very severely affected. Here you can see the attempt at the previous surgery. Here's his cavernous malformation, significant above and below the tentorium. So we make this little lateral approach to the cavernous malformation. You can see the tentorium. Because some of it goes above anatomically, we open the tentorium. Fourth nerve is completely safe because it's in the subarachnoid space. As long as we don't violate this, it's at no risk. It's down below. Then we retract back the tentorium with a little bipolar coagulation. We make a small opening and we get to the lesion. And once we've identified the lesion, then we create space by taking a portion of it out. These are small dissectors of mine that I love in different shapes that are also made by Cogent. And then we remove this cavernous malformation piecemeal. And I won't bore you with the taking it out, but here's the post-op. It's all gone. And the referring neurosurgeon writes me 5 months later, he is now able to ambulate independent with much better balance. And this is the follow-up at that point in time. So the final one I go for this particular approach is this young 15-year-old from Copenhagen who has this cavernous malformation descending all the way up to the foramen of Monroe. And we use the same approach, obviously opening the tentorium, no retractor at this point. We're down to the ambient cistern. We go through the medial lemniscus to get into the cavernous malformation, and then just remove it piecemeal. Notice, despite the fact that this is not the sitting position, we're not using any retractors. I've used the little CO2 dissector, and we just keep removing it and removing it piecemeal until, with image guidance, we know we're all the way at the end and it's all gone. And there's the post-op, and she is going home. OZ approach, another workhorse. When you have a lesion like this here, it's very straightforward. You want to go lateral to the motor fibers. And here it is after it's been removed, tolerated very well. More difficult is this patient, 20 years old, who's had 3 hemorrhages, and here's the cavernous malformation. So how do you get there? Well, by far, if you look at it, the most rational pathway is this. So we go contralateral OZ approach. And as this is exposed, internal carotid artery, optic nerve, I find that the best path to get into the peduncular space is between the optic nerve and the internal carotid artery. And then we depend so much on image guidance, make sure that it's accurate. And here's the contralateral peduncle. And we open a path parallel to the fibers, and we find the cavernous malformation. And with these tiny little pituitary-like forceps, we remove the cavernous malformation. And there's the pathway we came, and it's gone. Contralateral transcallosal, I've already showed you one. Here's one sitting over here, a 51-year-old with headaches. So coming this way makes the most sense. Because of time, I'm not going to show you this, but it's really very straightforward as long as you follow the correct pathway. And there it is. Almost looks like you weren't there, empty cavity. More difficult is this here. Third ventricle, roof of the third ventricle. How do we get there? Again, I emphasize I like the horizontal position, always across the sagittal sinus, so you can pull the dura and get a few more millimeters going through the corpus callosum. Foramen of Monroe. As opposed to the textbooks, I like going lateral to the choroid plexus. And that is so that we can protect the fornix even more. So now we have the choroid plexus protecting the fornix. Now we open, we go directly into the third ventricle. And then we remove the cavernous malformation. In this case, I use the little CO2 dissector, which is a nice way to retract and remove it, keeping intact the internal cerebral veins. And then pulling it out. And you see this position, I mean, it's really very comfortable, no retractors in place. And here it is gone, normal exam. More difficult is this gentleman from Israel with this cavernous malformation, which is very symptomatic, really sitting right in the back of the third ventricle and in the aqueduct. Here you can see it very nicely depicted. So here we are, same approach as last. Here we are in the third ventricle, coming down to the entry into the aqueduct. I have a firm retractor to hold the corpus callosum over, but here's the cavernous malformation, and now we gently remove it piecemeal, wanting to keep every structure intact until we really get it all out. one little bit at a time. And then spending a lot of time with little sharp forceps, make sure we have it all. Pre-op, post-op, pre-op, post-op. I want to end up with this last case, which is a little 6-year-old Italian mother. The father was family that owned many hospitals in Mexico. He had a sudden event that required a shunt, had mild ataxia. They operated for 16 hours with severe blood loss and never got a diagnosis. Another attempt was made in the United States in Houston, also was stopped because of extensive blood loss. When you look at this lesion, this is obviously a cavernous malformation, but it's inside the sinus. And the cavernous malformations that are inside the vascular venous sinuses are much, much different in the sense that they have robust blood supply. And so when you look at this lesion, this is an angiogram. You can first see where the sinus is occluded. And Dr. Albuquerque was able to get one little catheter in one little channel that was left. And look what he was able to accomplish. All this onyx into that lesion. So at surgery, the first thing we did was we made the craniotomy bigger than the original one. I cut the transverse sinus on both sides. And so I had a completely avascular lesion. Removed it. You can see the sparking from the onyx. Obviously no retractor, it's right on the surface. Really very straightforward to remove once we had the sinuses tied off and the tentorium cut. And there it is out. There's one end of the sinus, there was the other. So here's this beautiful mother. I was very disappointed when she kissed him instead of me. But here's the empty cavity. And 1-year follow-up since his surgery. He's the best in his soccer team, and he's also a very good student. And here you can see sort of the empty cavity, the rearrangement of the posterior fossa. Pre-op, 9 years follow-up. He is an excellent student, an excellent soccer player in college. So what are the safe entry zones? Well, they're depicted here. And as long as we know our anatomy and we study what we have learned from others, we can design a pathway really into these regions with relative safety. And there are very few areas in the deep portions of the brain that we cannot get to. We have summarized our experience in 2 atlases at TIME that also have all the videos included for these various approaches. So in conclusion, I would say surgical resection of cavernous malformations that are symptomatic and accessible is reasonable. When not to operate is of equal importance. Remember the study of ours in which almost half of the patients were sent to us for surgery. We recommended conservative management. Knowledge of approaches is obviously the secret. Image guidance and minimal retraction, I think, are essential for getting the best results. Appropriate exposure allows resection of virtually all cavernous malformations. I thank you very much for your attention and be happy to answer any questions you may have.
Thank you very much. An excellent presentation as always, and very informative. It's difficult to collect questions from audience, so I'd like to take advantage of being chairman. I'd like to ask you a couple of questions first, then ask audience to ask some questions. That'll be okay. Many neurosurgeons, I think, listening today from developing countries. And your technique and technology is so impressive, but sometimes it's difficult to be availed. And you mentioned about image guidance always. But if the armamentarium is limited, how would you recommend most essential thing that you have to have with, when you operate deep-seated cavernous malformation in terms of image guidance? And how about the monitoring? What monitoring system is important if you want to operate cavernous malformation in the brainstem?
Yeah, Professor Kobayashi, that's an excellent question. And for me, when we talk about neurosurgery is really it's a specialty that has very, very little impact on society. We are a luxury for a society to have a specialty like neurosurgery. However, for the individual patient, we're very, very critical for the single person that's affected. I would say that in a country where you have limited resources, your indications change. You wouldn't do the one where you know that you're going to have trouble getting to the lesion. But if on a CT scan you have a large hemorrhage and it's in a location and you know your anatomy, then you use your anatomy, you use your relative knowledge of the structures that you can see visually and create a pathway. I mean, in these areas that were operated on 20 years ago, before we had image guidance like this here, we just didn't have as many approaches. So I think for me, making a decision for a patient is very straightforward. If you just imagine it's your loved one that's in front of you that has that problem, what would you do? And if you're guided by that principle, you will do the right thing.
Thank you very much.
Same thing with monitoring. I mean, monitoring, you don't have to monitor every patient with every possible technique. You make the decision that you think is safest.
Thank you. One more question I have before going on to questions from other people. I have done not so many cases like you have done. I have been wondering about the consciousness alteration after surgery. We learned a lot about the consciousness, mediated by ascending reticular formation of the brainstem. But we are operating on the brainstem itself. And I myself haven't seen many patients have changed their consciousness. In your experience, how do you think about the consciousness alteration after surgery in the brainstem in particular?
Yeah, that's a fascinating question, because we know that in children, when we operate and we get in certain areas of the cerebellum, you can have mutism for a long period of time that usually recovers. I have not really studied alteration in consciousness in the brainstem, but I have not noticed any change in consciousness. And yet, when patients present with their hemorrhage, consciousness is very often part of the presentation. But I have not seen alterations in consciousness from the approaches that we've used.
Thank you very much. Dr. Raja, please go ahead, asking some more questions from the audience.
Thank you, Professor Spezra. And I listened to your presentation for several times. Last time you presented in the UHA Hernisnemis Grand Round. you attract there's around 5,000 audience. It's a huge number. And congratulations again. And I learned a lot from your presentation. And I also did some brain stem cavernous malformation resection, especially the safe zone philosophy give me a lot of help. Thank you again.
Okay, Professor Spertzler, it was one of the best talks I have listened. Two questions to you. Your thoughts on gamma knife for cavernous malformation, and also you mentioned about extraaxial cavernous hemangioma or the transverse sinus. But your again thoughts on extraaxial cavernous hemangioma, the cavernous sinus. Histology is same. They behave totally differently. They don't bleed. Your comments, Professor Spertzler.
Yeah, very good question. So, gamma knife for cavernous malformations within the brainstem or spinal cord, in my mind, do not have an indication. However, cavernous malformations, for example, in the sinus, because they're very vascular lesions, their radiation is really quite effective. So if you have, and it makes sense because when you have cavernous malformation, which has very little blood in it, they're venous components. Radiation is least effective on the veins. It is much more effective on the arteries, the small vessels, etc. So they're an indication, if you have one in the cavernous sinus, for example, a cavernous malformation within the cavernous sinus, radiation is really a very good tool. Outside of that, I'm not in favor.
Thank you, Professor Spertzler.
Bob, can I ask a question?
Why am I not surprised?
Bob, you showed some wonderful cases, and you approach lesions in various corners and nooks and corners. In your definition today, after your elaborate experience, what is the role of, is there any cavernoma which you will say, I will not operate or I will do conservative? And what are your indications, if any?
Well, I thought I sort of covered that, but as I said, if you have a cavernous malformation, as an example, below the floor of the fourth ventricle and no symptoms, follow. Also the history of the patient, the age of the patient, the size of the cavernous malformation, whether it's familial cavernous malformation. So we had a lot of patients that had familial cavernous malformations in Phoenix. And Dr. Zabransky, my colleague, really did a longitudinal study and found that 6% annual change in the cavernous malformation, either a little asymptomatic bleed or a new cavernous malformation. So they're very dynamic lesions. And the philosophy for them is to operate on them when they become symptomatic and follow all the rest. So I think a conservative approach to the right lesion is very appropriate.
Thank you, Bob.
Thank you very much. I would like to ask Professor Spertzler one question that it is very surprising to know that you turn away patients who come to you for surgery. But in this cohort of patients where you advise conservative management, if any of them require blood thinners for other medical reasons, what is your advice to them? Are the chances of bleeding any higher than the people who are not on blood thinners?
I think a cavernous malformation, the evidence that aspirin or any of the other modifiers of platelets increases the risk of bleeding, I don't think is present. I don't think we have the evidence. There's some logic to it that if you're going to have a bleed, it might be worse. But the vast majority of cavernous malformation bleeds stay within the cavernous malformation. The extra lesional hemorrhages can be absolutely devastating. Fortunately, they are the minority of cases. So when you bleed within a cavernous malformation, I don't think it makes much difference whether you're on aspirin or not. And following those patients doesn't mean that they will not come to surgery in the future if they have a bleed that then makes it accessible, has a large hematoma, etc. All the indications for surgery would still apply.
Thank you very much. Yes, my co-host Dr. Libun Singh would like to comment.
Yeah, thank you, Professor, for very informative presentation. I have two questions for Professor. Is the information about genetic have any role in your practice in terms of management of patient? My second question is, in those who are you treating conservatively, what are the role of surveillance imaging in those who are remain asymptomatic? Thank you, Professor.
Very good. I mean, we're learning so much about the genetics of these lesions. And I personally think they're very much a similarity between, for example, hemangioblastomas, where you have half of them that are sporadic and half of them that are familial. It has 3 cell lines. For cavernous malformation, we have 1 cell line. It's only the endothelial cell. Again, a very large number sporadic, but also a huge number that are familial. And so I think they're all part of these phacomatoses lesions. As far as surveillance goes, in general, what we request is an MRI scan every year. And if it stays very stable, then we switch to every 3 years. But they really get monitored for the rest of their life because we want to see the changes. We want to see if there are new lesions, that sort of attitude.
Thank you very much. I think it's time for the second lecture, but before we go, we would like to go back to our chair for his concluding remarks. Professor Kobayashi.
Again, Dr. Spezra, my friend, Robert, thank you very much for an excellent presentation. I think everybody enjoyed the presentation. Thank you again.
Thank you.
Thank you. Thank you very much, Professor Spetzler and Professor Kobayashi. I understand that you have to leave after your lecture has been, you have other commitments. So we are indeed so thankful to both of you for coming here and spending your time in support of the young neurosurgeons in Asia and across the world. Thank you so much, professors. Yes, I would like to go to our second chair, Professor Shubin.
Okay. The second speaker is Professor Shi Huaizhang. He is a well-known neurosurgeon in China, especially in the field of neurointervention. His first affiliated hospital of Harbin Medical University is the best neurosurgical department in Northeast China. And Professor Shi, his interventional procedure were numerous and with up to 16 procedures performed in several cities in just one day within 24 hours. So reflecting his high level of skill and organization ability. So let's welcome Professor Huaizhang Shi.
Thank you, Professor Xubin. It's my great honor to be invited to be here to share our experience about the intracranial arterial occlusion. I will share in this presentation. I will share my center's experience of the endovascular treatment of symptomatic chronic total occlusion of intracranial arteries. So for the CTO patients of the intracranial arteries, we should answer the 2 questions. The first one is the why we treated, and the second one is which lesion should be treated. This is the CCAST study was published as the stroke. This study includes 22 hospitals in China, including 2,864 patients with ischemic stroke or TIA within 7 days. All patients were examined by MRI to evaluate the diameter of major intracranial arteries. The data of the study showed the 1-year recurrent stroke rate is different among these 4 group. The highest is the CTO group is much than 7% per year. It's much higher than the severe stenosis and the moderate stenosis group. The same result, we can find the same result from the other articles. These articles published at the NEJM showed the same result. The risk of recurrent stroke as severe stenosis is 19%, but the CTO group is 23.5%. It's much higher, so it's different. So why the patient of CTO or severe stenosis patient have the much higher stroke recurrence? I think there are three mechanisms. The first one is the low hemodynamics, and the second one is embolism, and the third one is the mixed mechanism. And the first one, the hemodynamics, the reason I think is the main mechanism. The hypoperfusion, the result of the hypoperfusion not only is the stroke, the high risk of the stroke, but also the patient will have the cognitive impairment and the high risk of the dementia. Hypoperfusion at the distal end of the diseased vessel is the main reason can explain why the patient of the CTO patient leading this patient the cognitive impairment and the dimensions. This articles published at Circulation, they enrolled more than 4,700 cases, and the follow-up is 6.9 years. The data showed with the perfusion increased, the hazard of the dimension is decreased. So it's very interesting. And the other articles that showed the data that if we treated the CTO patient using the stent or using other ways, the patient after the operation, the neuroconnective will improve significantly. So the second question is which patient we should treat it. So I think if the patient has a symptomatic intracranial occlusion of vertebral arterial, basilar arterial, MCA or SCA, we should treat it. And the second factor is if the patient, we treat the patient with the aggressive medical treatment, but it's not effective, we will treat it. And the third one, if the patient is the hypoperfusion because of the arterial occlusion, we will treat it. And the fourth one is the patient have no obviously neurological dysfunction, and the length of the vessel occlusion doesn't exceed more than 15 millimeters, and the diameter of the vessels at the distal end of the occlusion is greater than 2 millimeters. So I will show some case in my centers. This patient from the left SCA angiogram, we can find the SCA occluded at the supraclinoid segment just after the SCA send off the ophthalmic arterial. And the right SCA, the right SCA angiogram shows there is no good collateral from the ACON. And the left vertebral arterial showed there are some collateral arterial from the vertebral arterial and P1 and the PCOM and ICA and MCA. From this imaging, we can find the MCA, left MCA from the vertebral arterial. supply. So from this, the image, we will know the proximal of the occlusion is just at the ICA supraclinoid segment, and the distal is just at the PCOM. It's at PCOM segment. So it's a very short. It's a very short. I think it's a good indication to reopen the ICA. Before the pre-operation, we take a CT perfusion examination for this patient. The MTT and the TTP showed in the left side, the TTP and MTT is much longer than the right side. And the CBV and the CBF showed the left side is quite different from the right side, showed is a hypoperfusion in the left side. So if the patient, we don't treat it, the patient will have the higher risk of the stroke recurrence rate. So we treated the patient, and we are very lucky. We now get the microcatheter and the guide wire across the lesion and to the M3, and we take the super selective angiography through the microcatheter. We should make sure the microcatheter is in the true lumen of the M3. It's very important to avoid if the microcatheter in the dissection is very, very dangerous. And we now get a small balloon, gateway balloon, 1.5 by 15 through the guide wire and to the lesion and inflated balloon. And we changed a bigger one. Gateway is a 2.5 by 15 balloon to inflate it again. And after that, we found a good result. The ICA reopened, and the MCA, M2, M3 is a good. So this is the final result, the AP view and the lateral view. After operation, we take a CT perfusion examination again. The MTT and the TTP showed that there's no obviously difference between the two sides, and the CBF and CBV is the same. So the patient we get a good result of this patient. This is a second case. This case we take from the left vertebral arterials, the angiogram, we found the left vertebral arterial is dysplastic. After the left vertebral arterial send off the PECA, the wave 4 segment is very thin. And the right vertebral arterial angiogram showed the right one, right vertebral arterial is the dominant arterioles, but it occluded at the V4 segment. Both sides, the ICA showed there's no good collateral from the PCOM to the basal arteriole. So we will treat this patient. We take a dual roadmap to make sure to make sure the distal of the lesion and the proximal of the lesion. This is we should treat it segment. We navigate the microcatheter and the guide wire across the lesion to the basal artery and make a super selective angiography to make sure the microcatheter is in the true lumen of the basal artery. And after that, we use the same same way to treat it. We now get a small balloon, is the 2 by 15 gateway balloon to the lesion and inflated twice time. This is the final result. This is after the balloon inflated, we deployed a stand. The stand is the self-expanding stand. Is the enterprise 4.5 by 37. It's a long stand, self-expanding stand. After that, this is a final result. It's the AP view and the lateral view. The third one is the basilateral occlusion. From the right vertebral angiogram, we found the basilateral. From the basilateral, the lower segment is occluded. From the right ICA angiogram, we found the basilaterals, the upper segment of the basilaterals, collect from the right PCOM to the right P1 and to the basilaterals. So from these two image, we know the occlusion lesion, the length is very, very short. So we will treat it. This is the left one is the proximal segment. The right one is the distal segment. But it's not easy. It's very hard to navigate the microcatheter, to navigate the guide wire across the lesion. But I'm very lucky. We navigate the microcatheter to the distal basilateral and make a supraselect angiogram, make sure it's true lumen. And after that, it's easy. We navigate a gateway 2.15 small balloon through the guide wire to the lesion and inflated the balloon. And this is the final result. Still have some stenosis, the residual, but I think it's good. This is fourth case. The fourth case is M1 occlusion. This is the lateral view and this is the AP view. From this view, we found we should identify the anatomic structure of the occlusion. It's not strange, it's a curve here. So when we try to navigate the guide wire through the lesion, we should know the anatomy of this vessel. It's not easy to get through the occlusion, but at last we succeed, and we navigate the microcatheter to the M2 and take a supraselect angio showed it's in the true lumen. And we navigate the gateway 1.5 is the smallest gateway, 1.5 by 15 inflated. And we deployed a self-expanding stand. It's the final result. It's the final result, the lateral view and the AP view. The last case is the ICA occlusion at the cavernous segment. This MRI pre-operation and the CT perfusion pre-operation also showed the right side is hypoperfusion clearly, and this is the angio. We found the occlusion at the cavernous segment. Sorry. So I will treat it I will navigate the map caster and the gateware. It's not very hard but here we found this is the occlusion side, so it's not easy. But at last we succeed. This ophthalmic arterial, the gateware in the ophthalmic arterial, and we changed the way, and at last we now get the map caster to the MCA. And we take a super selective angiography through the microcaster, and we make sure the microcaster is in the M3. And after that, we navigate a gateway balloon, 2 by 15 balloon, to inflate it for fourth time, I think fourth time. And after that, we deploying the Apollo. It's a balloon expanding stand. The first Apollo stand is 3.5 by 23, and the second one is the 3.5 by 18. This is the final result. This is the final results, the LAT view and the AP view. Okay, so conclusion, we found there are some factors affecting the recanalization. The first one is the time. If the patient occlude, the time is not very long, I think it's very easy. If the time is very long, more than 3 months, more than 1 year, it's very hard to reopen the arteries. The second one is the occlusion site. The third one is the length. The length is too long, it's not very easy. The fourth one is the type of occlusion. The last one is the imaging characteristic of occlusion. So I think the recanalization of the intracranial arterial occlusion is a really high risk procedure compared with the stenosis, intracranial stenosis. So we should strictly select the patient. Indication is very, very important for this technique, and we should know when we should stop when it's time to stop. It's very important. Thank you.
Thank you, Professor Shi, for your very nice presentation. So I have 2 questions for you. So before you try to recanalize the vessel, do you take some examination for the plaque which occluded the artery, and analyze if it's soft or very hard with some calcification plaque, that it's very hard to penetrate the guide wire's tip. Do we have some?
Yes, it's a good question. So in most cases, before the operation, we take the high resolution MRI examination. I think it's very useful and very important to evaluate if the plaque is hard or it's soft, and we can make sure from the HRMI to make sure how long, what's the length of the occlusion, the site is useful. And the second aspect, if we treated the patient before the from DSA from DSA imaging, if the proximal is very it's not very sharp. It's not very sharp. I think it's very hard. The plaque is very hard. If the proximal shape is very sharp, I think it's soft, because the sharp means the time is not very, very long. So I think the HRMI and the DSC is the proximal shape. These 2 points is useful for evaluating if the plaque is hard or soft. Yeah.
Okay. The second question is because when we put the implant the stent in the ICA from CCA to ICA, we use some spider to catch up the plaques from the sometimes from the plaque. So with this small vessel reopen, actually you don't use some protection device. So
Yes.
is there any distal occlusion from the small plaques?
Yeah. Yeah, I think yes. I think maybe in some cases maybe small embolites will to the M3 or the P3. But I think because it's a chronic, not emergence. So if we reopen the big arteries, if there's some embolics go to the small arteries, I think it's good. It's good. Yeah.
Okay. How about the long-term follow-up?
Yes, it's a good question. We have done about more than 50 cases in the CTO of the intracranial arterioles, and about half cases we take a follow-up. It's not very good, as good as the intracranial stenosis study. Yes, it's have much higher re-occluded and re-stenosis rate. Yeah, so maybe at first we use we use the balloon. It's smaller than the arterial, so the residual stenosis in the procedure is much higher than the intracranial stenosis study. So maybe it's the reason. So next time maybe we should use the big one, big balloon. Maybe it can decrease the stenosis. Yeah.
But the bigger balloon maybe cause some hyperperfusion.
Yeah. Yes. Yes.
So that's another problem.
Yes.
So that's why I prefer to use open surgery to do a bypass.
Bypass. Maybe. Yes.
Okay.
Okay.
Raja, do you have some question for Professor Shi?
What is the when you fail to recanalize through endovascular? When do you recommend bypass? Is it immediately or you wait for some time? And after you recanalize it, do you routinely give blood thinners like aspirin or heparin or anything like that?
I'm sorry, 许巍，
他问关于术后用不用阿司匹林之类的，还有就是如果是脑梗以后什么时间做这个开头
Usually we treat the patient after the stroke, after 1 month. After 1 month after stroke, we will treat the patient. The first question, and the second one we will use the aspirin and the Plavix double antibiotic. Yeah, before operation and post operation. Yeah.
How long use after the operation?
Yeah, at least 3 months for both the aspirin and the Plavix, and after that we will take the follow-up. If the vessel is good, we will change to just the aspirin or just the Plavix. Yeah.
Thank you. Yes, my co-host.
Hello, thank you, Raja. Thank you, Professor. I want to ask from Professor, when you do the imaging study for the proximal and distal flow of the obstructed vessel, and also with your high resolution MRI, how do you make a 3D reconfiguration of the direction of your catheter, and also what are the length where you would not do the procedure? Because you mentioned that most of the time they are good distance, not too far away. So what are the cutoff point for you? Thank you, Professor.
他是问这个高分辨核磁的判断吗？you mean I'm sorry. You mean the high resolution MRI?
Yeah. Do you always do a 3D recon to actually give you a mental, a 3D information on how you're supposed to guide your guide wire? And my second question is, what are the distance that acceptable for the procedure? More than certain distance that you would not do the procedure. Thank you, Professor.
用不用3D 的重建来指导你的这个手术？
Yes, it's very useful for the 3D DSA because the way for the intracranial stenosis or intracranial occlusion for this procedure, we should navigate the microcatheter and navigate the guide wire far, very far than the aneurysm case. So M3 or P3. So we should know the distal, the small arteries, the anatomy. So 3D DSA is very useful for this case. So in the operation, we usually to change the working angle to make we make clearly we know the distal arterial. So we make we should navigate the guide wire to the true lumen in the arterial. In some cases, we maybe make fault to navigate the guide wire to injure the small arteries. So it's very dangerous in this case. Yeah.
Right. Thank you, Professor. So much. Are there any questions from the audiences? There has been one question from Ayman Mayas who says, what apparatus do you use for catheter angiogram and CTP?
Yeah, CTP.
What apparatus do you use for catheter angiogram? I did not understand that question myself. And maybe she's asking for company. Which company do you use?
Which company? CTP?
Catheter angiogram.
是他们用什么？
I'm not sure about his question. It's microcatheter.
Maybe she's
angiogram
asking.
Depends on what kind of microcatheter you prefer to use.
I think the echelon, the Medtronic echelon Larit, is a good microcatheter, and the guide wire I love the Traxis from the Microventions company. The guide wire is very useful to the distal arterial. It's very soft and it's very safe. Yeah.
Dr. Hidohito Kimura is here. Professor Kimura.
Thank you, Roger. Hello. Good evening. Thank you. Thank you, Professor. Thank you for excellent and informative lecture, and Professor C.
Thank you.
So I think it's also the indication is very important issue for the treatment of the chronic occlusion, intracranial occlusion, artery occlusion region. So as you know, there are no major randomized control study failed to show the efficacy of the recanalization of the major intracranial arteries. So do we need to treat the patient with asymptomatic occlusion in the patient with a severely impaired visceral cerebral blood flow? I want to make sure you have indication of this technique. Do we need to treat the patient for the asymptomatic lesion? Thank you, Professor.
无症状的做不做？
Now, if the patient is have no symptomatic, I don't treat it because I think the reopen the arterial for the CTO patient is very dangerous. I think it's very dangerous. It's much dangerous than the intracranial stenosis. In my centers we did a lot of intracranial stenosis patient for using the balloon or using the stand, but for the CTO I think it's much higher. The risk is much higher. So we just treated the patient is have some symptomatic. Yeah.
Yeah, thank you.
Right. Thank you so much. So we don't have any further questions. We can go back to our chair, Mr. Shubin, who can give his concluding remarks.
Okay, thank you, Raja. So today I checked the audience number. It's around 1,200. Thank you again.
Thank you. Thank you so much, Mr. Shubin, for helping us to broadcast this webinars across China. So I would like to wind this up officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to sincerely thank both the speakers and chairs for today, Professor Robert Schwetzler, Professor Kobayashi, Professor Shi Hui Zhang, and Professor Shubin for coming here and teaching us about the respective subspecialties. Thank you so much, all the distinguished faculties who joined, Professor Suresh Nair, Professor Atul Goel, and everybody else, and also Professor Kimura Sensei. Thank you, my dear co-host Lubin Singh, for being my co-host for today. So until we all meet on next Wednesday, it is bye-bye from all of us. Thank you all who joined, and a very, very happy Easter to all of you.